Okay, good evening, everyone, and welcome to ATP Live Monday. All right, I just see. I don't know what's going on with Instagram again. She'll be going live, but it's not connecting. Okay. I'm not really sure why the Instagram section doesn't go live. Okay, welcome to ATP Live Monday. And today is also the last day of June 2025, and something lovely. I hope you've had a lovely half of the year, and something wonderful is happening in July, which I'll be telling you about. And of course, some of you know already. Just setting my ring lights. Okay, seems to be falling off. Okay, all right, stay still. Okay, good. Welcome. I think I have to go live on my phone for Instagram. I don't know why it's not connecting. It's just another drama today. Okay, I think I should just go live on my phone so I won't waste time. Okay, so welcome to ATP Live Monday, whichever platform you're joining from, on Facebook, on Instagram. I'm just going to go live on Instagram. It's not connecting. I don't know why. So let me go use my phone. Okay. I think this is okay. All right. Okay. Okay. So welcome everyone. I hope you've had a lovely day. Thank you so much for joining us. ATP Life is brought to you by Atp Paediatrician's Foundation. So this is a program where you get to ask any questions that you may have about the health of your children, and we try to answer them in 60 minutes. So before we start, I just wanted to help us share the video and so that other people can see us. And then we can start. Thank you so much for those joining me on Instagram. Sorry for starting a bit late. I seem to have some technical issues again with Instagram today, but no worries. We are good to go now. All right, so feel free to share the video and invite friends and family. I'm also going to do the same. We just got 1 hour to answer any question that you may have about the health of your children. And then we will be offline. But remember that you can always ask any questions that you have about your children on our Facebook groups from Mondays to Saturdays. So even after the live session, that is not the end of it. You can always ask your questions as well. All right, let me just share the video and then we can start. I just want to share quickly to our groups so that people can see and they can hear. And if you have any question, you can start to drop your question. Okay, somebody say you can't hear my voice. Okay, let me see whether my volume is low. Apologies, Mary. Mary, can you hear me now? Okay, apologies. I'm supposed to go. Okay, so just let me know if you can hear my voice now. I'm just going to share to the groups and then we can start. Yeah, okay. Thank you, Mary, for letting me know. I think my volume was on low. Okay, so welcome, welcome, welcome. Instagram, Facebook, YouTube, whichever platform you're joining on. Welcome to ATP Live Monday, the last one for the month of June and for the first half of the year. For us in ATP, actually, this is the end of our year. ATP year runs from July to July. So actually, this is the end of ATP year 2020. That should be 2025. Okay, so thank you so much for joining us. So let's just share the video. And if you have any question, you can start to ask your questions now. Remember to start with the age of your child, please. The age of the child is so, so important to a pediatrician. We cannot answer any question without knowing the age of the child. So let me know the age of the child and then try and be concise with what your concerns is. Don't just give us information without asking questions. Yeah, people do that a lot. They just give some information and just leave it hanging. And I'm always not sure what they want me to do with that information. So please try and be very specific with what you want us to do with the information you've provided so that we're on the same page. Okay, I think I'm almost done now. I just need to quickly pin the video and then we can start. But feel free to start asking your question now. You can start now. And I hope your first half of the year has been lovely. Okay, so I'm almost done. Yeah, so Mary, welcome. Thank you for joining us. If you have questions, please ask your questions now. Start asking your questions. Let's start to answer them. And I have a lot of announcements for you. So I will need us to finish the main thing first, and then we can now go to all my lovely, lovely announcements for you for the year, for the months coming up in July. For those of you who know, July is very strategic, very important for us on ATP. So yeah, we do a lot of things in July. Okay, I think I'm done with all the pinning. All right, pin. Okay, lovely. Okay, so let me go back to my studio. Good evening, everyone. Yeah, I can see you on Instagram, on Facebook. Thank you so much for joining me today. Once again, let me just welcome you to ATP Live Monday. This program is brought to you by Atp Pediatrician Foundation, and we are committed to the health and the well-being of your children. And so that is what we do. So ATP Live Monday is one of our programs where we get to answer any questions that you may have about the health of your children. And I try to do that in the next 60 minutes. But remember that if you still have any questions after the live session, not a problem at all. You can always go to our Facebook group and then you can post your questions there. And our groups are open Mondays to Saturdays. And so we answer literally thousands of questions every week. And so we are happy to support you in your journey of raising healthy children. Our vision is to make sure that no child dies from preventable causes. And we've been doing that for 10 years. Actually, it's going to be our 10th anniversary next month, and that is why we're so excited. There's so much we're going to do in July, so just don't go away yet. I will tell you all about it at the end of the live session. So I got a couple of questions already, so I'm just going to start answering those questions. Linda from Facebook, thank you so much. If you're on our Facebook groups, please click on the video to post your question. Otherwise, if you just put it on the group, unfortunately, we won't be able to see it in the studio end. But if you're on the page or you're on Instagram or YouTube, you can just drop your question directly under the video and I will say it. But if you're in the group, you have to click on the video if you want to ask a question. But if you are just listening, that's fine. You don't need to do anything extra. Okay, so Linda is saying my son has been having really dry skin on his back. It peels sometime, but it keeps coming back. What do I do? Okay, Linda, please start every question with the age of your child. Okay, I think you've given me an updated question after you you've realized that you didn't do that. So your baby is 10 months old. Okay, he has dry skin, he peels off. Okay, any remedies? So let's start by saying that for rashes or anything like that, we like to see it first. But unfortunately, for this live session, it's difficult for you to post a picture. But then dry skin, peeling off, coming and going is very typical of what we call atopic dermatitis or atopic eczema or allergic eczema or allergic dermatitis. It's just the same thing. But basically, it's a kind of a genetic condition. So people that have those conditions, they are born that way. They have this sensitive skin and they tend to have dry skin and they tend to, their skin tends to peel and all that. So it's a genetic predisposition. However, there are things you can do. Number one, you have to moisturize the skin a lot. Basically, when we say moisturize, it sounds like a big grammar, but basically we just have to allow water to remain inside the skin. So that is why the skin is dry. Your baby's skin is tending to lose water so quickly. So you need to apply products that will trap water onto the skin, and that's what we call moisturizer. That's just the meaning of moisturizer. So, and it has to be things that because people that have this allergic or atopic dermatitis, they have sensitive skin, so they react to some products, to chemicals. So you have to use things that are very what we call hypoallergenic, things that are likely not to create a reaction. So things that don't have so much of chemicals. Your plain Vaseline Blue Seal is good. Your shea butter Ori, even your olive oil, your coconut oil, those are very lovely products. Unfortunately, most of the other products that we buy in the shops that are very nice smelling and all that, baby care products, some of them are full of chemicals, and people who have those kind of sensitive skin reacts to those chemicals and it tends to make things worse. So the first thing you want to do is to keep the skin moisturized. Use natural or hypoallergenic products. I've given you a few names, even including the soap. You want to use black soap. You want to make sure that you don't dry the skin too hard or too vigorously. And sometimes this moisturizer you're applying, you have to apply it multiple times in a day. It's not those kind of you apply in the morning and that is it for the whole day. Sometimes you have to apply multiple times. So that's what we normally do. You have to keep your child's nails short because the dryness of the skin tends to itch them. So they tend to itch a lot. In fact, that itching is what most parents really struggle with. So you want to avoid the child scratching and all that. Sometimes we have to give them so sometimes using some of these strategies are enough, but sometimes they are not enough for some children. For some children, you definitely need to see a dermatologist, and then we can use other medications. So sometimes we have to use steroids. Sometimes we have to give them something to reduce the itching. The thing with atopic dermatitis, which most parents really struggle with, is that it is not a condition we can cure. Okay, it's a genetic thing. That's how that child's skin is. It's a genetic tendency, and you may have history in your family of people who have sensitive skin or who have other allergic conditions as well. Allergic conditions like asthma or rhinitis or allergic conjunctivitis and all that. So they tend to run together, and the same child may actually have multiple of those allergic conditions, what we call atopy. And so it's not something that is going to, because that is what most parents struggle with, the acceptance. So usually when I tell parents about atopic dermatitis, the first thing I always want parents to do is to understand that condition and understand that there's no cure that is going to make it disappear completely, because that's what most parents want. They want us to prescribe one cream and once you use that cream, and that will be the end of it. There's nothing like that. And unfortunately, people that sell stuff will always tell you things like that, but that's not true. So it tends to come and go. We call it was and wane. So those are the conditions. There are certain conditions that you cannot cure. You cannot make them disappear. They can come and go. You can try to limit how frequently they happen by avoiding triggers and all that, but you cannot completely eliminate them. So this kind of children, you also want to make sure you are exclusive breastfeeding them. You're not giving them formula because they can react to your formula as well, and it will break up in the skin. You don't just give them any drug or any products anyhow. You want to avoid anything they are allergic to. You want to avoid it as much as possible. But no matter what you do, sometimes they will have what we call phases where it will flare up, and then they will have phases where it will be quiet. So when there is a flare, then we'll treat it again. So most time, if the child are having the rashes again, we'll give them anti-allergy medication, something to reduce the itching. Sometimes we can use steroid for a short period. Sometimes we use other products like dermatologists will use. So it varies. It can be very severe in some children. It can be mild in some children, but it's a genetic condition. Some children will outgrow it as they get older. Some will always have the sensitive skin no matter what, even when they get older. So that is what. So usually at a parent, if really for those who have the severe kind that is tends to come up and go for a long time, your dermatologist have to be your friend. You have to keep seeing them, and you have to keep going for follow-up, and whenever there's a flare you see them as well. Don't get yourself frustrated trying to look for something that will make it all disappear, and don't self-medicate. Some of us start using all these triple creams like Fombactane. Some of those products are not meant to be used without prescription, and they're not meant for you to be using them every day on your child's skin like their cream. No, they're not meant to be used. So you have to be very careful that you don't go down that route, okay? Because it can be dangerous as well. So do your own natural, keep the skin moisturized, avoid chemicals, use natural products, keep the skin. So usually for those children, we don't dry their skin. When you finish bathing them, you just dab their skin. You must always leave a little bit of water. You don't use sponge to scrub them like some of us scrub people too hard. You don't scrub them. Sometimes you just use mild foam, and sometimes you have to add oil even to their bathing water, because you want to keep that skin moisturized always. So most of the time that is what we do. But if you're doing all these things and you're still struggling, you have to see the dermatologist, and then they will take it up from that. All right. So I hope that is helpful for Linda. So welcome everyone. For those who are just joining us on Instagram, thank you so much. Please ask your questions. I can't see any question yet on Instagram, but feel free to ask your questions. And if you're watching on our Facebook group, please feel free to also ask your questions. So I just want to make sure nobody is dropping questions where I can see them. Anyway, I can't see any right now. So welcome everyone. We just mentioned answering a question on atopic dermatitis. It can be very frustrating, especially for the mothers, because you've done everything you should do and it's just not working. So, but just hang in there, and you see the dermatologist, and they can always support you. It's a long journey, but the good news is that most children tend to outgrow some of these tendency as they get older. So that is that. Okay. I don't have any question yet, so let's go on. But while I'm waiting for questions, if you have questions on Instagram, feel free to ask your question. While I'm waiting for more questions, I just want to I've got a lot of questions about diphtheria, and we've already talked about diphtheria before. I think we have not less than 2 or 3 podcasts on diphtheria, but obviously people tend to look for information when they are having the challenge. So I just, and it seems that there have been a lot of outbreak of diphtheria. I know it started in Lagos, King's College, and we did a talk about that, but some people are still asking a lot of questions about it. Let's start by saying that diphtheria is a bacterial infection. Okay. And a lot of people are asking me, is there a vaccine? Is there a vaccine? I'm like shocked that many people don't know that we have diphtheria vaccine. We've always had the vaccines. It's part of your DPT when we're doing DPT, then we move on to Penta. So it's part of Penta. So it's something we've been given to our children. So it's not like it's something new. The only challenge is that we give our children 3 doses. We give them 6 weeks, 10 weeks, and 14 weeks. But ideally, we should be giving them booster doses by 18 months and 5 years. Unfortunately, we don't have the booster as part of our current immunization schedule. So that is because ideally we shouldn't give the Penta as a booster. We should actually give there's a particular kind of diphtheria vaccine, either with tetanus toxoid, that we should be giving only as boosters, which most of us don't have right now. So, that's the major issue with diphtheria. But the way people are asking about diphtheria vaccine are like, people don't know we've always given diphtheria vaccine. We've always given diphtheria vaccine. It's already part of your DPT or Penta, depending on which one. But obviously, the children runs out by the time they're about 18 months, the immunity begins to wane. And what we need to do is to give them a booster dose. And now that we're having outbreak, I guess the government is also giving booster doses. That's number one. Number two, vaccines are not something you go buy in the markets. Okay, vaccines are things you get in your hospital or health centers and stuff like that. Then people were asking me about giving antibiotic as a replacement for the vaccine, like instead of the vaccine or the booster, can we just give antibiotics like azithromycin, erythromycin, all those kind of antibiotics? Now let's explain by saying that vaccine is not the same as antibiotics. They are two different things, okay? Vaccine is part of that organism you're trying to prevent. So we take part of that organism, either the whole organism itself, and we kill it and then give it to you so that your body will produce a response to it as if you are getting that infection. But remember, it's a killed organism, so you're not going to get the infection, but your body is going to produce a response that will help protect you when next you're actually exposed to the real organism. Or we take part of that organism or its products and modify it in the lab, and then we give it. That's what we give as vaccine. So then your body produce what we call immunity or antibodies to protect you against that infection in future. That is the vaccine. Antibiotics is meant to kill the organism that is already in your body. Okay, so if you take antibiotics, it's not the same thing as a booster dose. The antibiotics assume, so people were given antibiotics to assume that if you've already been exposed to it, before you start having symptoms, let's just give you antibiotics to kill the germ, the bacteria, before you start to have symptoms. That is just for that particular period. It doesn't protect you if you, after 1 week or so of your antibiotics, if you're exposed to diphtheria again, you're going to have diphtheria because the antibiotics only kill that particular germ that is already in your body. It doesn't protect you against future infections. So taking antibiotics is not the same thing as getting the boosted vaccine, and it is never a replacement for it. So for those who are confused about that, so I just feel like I should address that. I hope those who are asking questions about diphtheria are here and they've gotten the answers. But if you still have any query about it, please feel free to ask. All right, I got OBG. IG Rosie. Good evening. Can sepsis be transferred from mother to child? That's a very lovely but loaded question. Okay, if strictly speaking, we don't transfer sepsis from a mother to a child. So in other words, you're not going to give your child, when you say sepsis, sepsis means there are germs, usually bacteria, multiplying in the blood of the mother that is making the mother to be sick. That is the meaning of sepsis. So there is no way, unless you take half of your blood and you transfuse it to your baby, there's no way you're going to get sepsis past to that baby, okay? However, so strictly speaking, sepsis is not something you transfer from mother to child. So we talk about mother to child transmission of certain infections. HIV is one of them. Hepatitis B, one of them. These are infections that if a mother has, she can transfer to her baby, either in the womb, during pregnancy, during delivery, or through breast milk. Those are the true mother to child transmission of infections. So malaria is not one of them. For just to quickly add that, because a lot of people ask me, I have malaria, I'm breastfeeding, is maybe going to have malaria. Maybe it's not going to have malaria from you because you have malaria that way. So malaria is not mother to child transmitted. The same thing with sepsis. However, there are certain infections that if you have as a mother, especially when you're pregnant, and if you're about to deliver your baby, you can actually pass it to the baby through a direct contact. For example, some mothers have what we call group B streptococcus. It's a form of a bacterial infection, and that bacteria kind of stay around the vagina area. So when the baby is coming out of the womb is actually sterile. But once you break the water of the mother, the amniotic membrane is broken. That means that protection that baby has against all the germs out on the mother's body is broken. So those germs can move into the to the baby from the mom's vagina. They can move to the baby, or when the baby is coming out through the vaginal canal, those germs can get onto the baby and cause infection. So that is a way. Also, if you have illness, for example, if you have sepsis and you also have like wounds, or like you are generating pus and all that, and you are not being careful with your hand washing and stuff like that, you can get the baby to contact it, just physical contact, and then that baby can also be exposed. But it's not a typical transmission that you give through blood, through breast milk. Those are the ones we actually meant by transmission. So if you are sick with infection and you are on the hospital, you can breastfeed your baby, and your baby is not going to have sepsis just because you are sick. Okay, you just need to get treated. Okay, so I hope that is clear about that. I have a friend that lost two sons to sepsis within the first 4 months of their lives. I try not to comment on third-party questions, okay? There are a lot of things we would like to ask about your friends and the loss of those babies. You can only know what people tell you. There are many things they will not tell you as well. So definitely it is not a very common thing for that to happen. Number one, sepsis is not something that happens recurrently. That is number one. It's very unusual for you to have sepsis with your first baby, then you have sepsis. Sepsis is not like an HIV or hepatitis B that stays with you. No. So you have sepsis, it's just like having a boil or malaria. You get treated and you're okay. It would be very, very unfortunate for you to have it the second time to start with. So then for you to now lose two children from it, the probability is almost next to zero. So I can almost bet that those children didn't die because of sepsis. Okay. There may be other issues that those children have, or other things that have happened. Then sepsis may be the last thing that took them out, unless the mother herself has what we call immunocompromising condition. For example, if your mother is HIV positive and her immune system is so, and then that means she's not being treated, because these days HIV is almost like another chronic infection that you treat and you are okay. So so it's very difficult for you to make this kind of generalized statement. We definitely need to have more information. But what I would just advise for your friend is that she must see a pediatrician, she must see a gynecologist. Before she get pregnant again, she needs to have unfortunately, Nigerian mothers, we just get pregnant. No, this kind of scenario, you don't just get pregnant. You need to see your doctors before you get pregnant. We need to know why those babies died. If we don't know, we may need to investigate. We need to do a lot of things. Then what can we do? And do we need to keep you? Do we need to monitor the baby? But the babies may have, well, according to the mother, say, let's take a word for it, that babies die from sepsis. But it's very unlikely for two babies to die from sepsis and die around the same age of 4 months. No, there's something else going on. These children may have genetic conditions. These children may have other issues that maybe when they get to 4 months, that is when they have, you know, like a crisis point or something. There are certain conditions that can, like metabolic disorder, they are very rare conditions and they tend to be genetic. That is why they tend to be recurrent. And unfortunately in Nigeria, we don't do a lot of genetic tests, but these are the kind of cases that you need to do genetics. And we even would test the baby in the womb sometimes, and we need to know why, and we need to advise the mother. We need to do genetic counseling. Is this something that, is it even safe for her to have another baby? Is this something that can happen again? Are they boys or girls that died? There are a lot of issues there. But bottom line, she needs to see a pediatrician. And I hope they were in the same hospital. If it's not the same hospital, because that's always the issue. People have bad experience in one hospital, then they leave and go to another hospital. The old one, they didn't know what happened the last time. The new people didn't know and nobody is making it. It's not tying it together. It's very, very important. So she would definitely need to go to a teaching hospital, preferably. And she needs, before she even get pregnant, she needs to have a detailed consultation with a gynecologist and a pediatrician, and then they need to know. She must know why those children are dying first. If they've not done autopsy, they should have done autopsy on those babies and things like that, and even genetic testing and all that. So, but I'll leave it at that. So, but just to summarize, sepsis is very unlikely to happen twice, and unlikely to kill babies twice, and unlikely to be from their mother. so many unlikely in that scenario. Okay, my baby is 6 months. She only take NAN 2. She does not collect other food. Okay, let's just start by saying that NAN is not complementary food. Kemi, NAN is not complementary food. NAN is formula. And we want your baby to go on complementary food. So what was your baby on before 6 months? Were you doing exclusive breastfeeding or were you doing formula feeding? All right, so that's the first question I would like to ask. If you are still there, just answer that. If your baby was on breast milk, you should keep breastfeeding, and then you need to introduce solid for the child and not formula. Okay, but if your child was on formula before and you're only changing from your formula type based on the age to another formula based on the age, that's okay, but your child needs to take more than formula at 6 months. Your child needs to be on complementary food. If you go to our Facebook group, we already have a guide session, because baby not eating is like number one question on frequently asked questions to the pediatrician. So we're already prepared for that. So we've talked a lot about it. And your baby is just 6 months, okay? So it is too early for you to say your baby is not collecting any food. You have not tried. You have not even tried for 1 month, and you say your baby is not collecting any food. There's nothing. It's too early to say that, okay? You are just starting complementary feeding. So we don't expect your baby to start. How many food have you tried? You couldn't have tried all the food possible in 1 month, because your baby is just literally 6 months old. So you just literally started complementary feeding. And it may sound like these are things that we should know, or like it sounds like it should be taken for granted that people should know that, but mothers need to understand that when you're starting new food, you need to try it for a certain number of time before you move on. Okay, there's no way you've given this baby all the food possible. So to even make a statement and say my baby is not collecting any other food is part of the problem I have with mothers doing complementary feeding, because we already make a lot of assumptions. So if you give your baby pap or maybe cereal or one of them for 1 or 2 days and maybe didn't take it, then we can come up and say my baby is not taking another food. No, that is not correct. Technically not correct. Number one, you need to offer a baby one food for at least 1-3, that is 13 times, before you say that baby is not taking that food. That is number one. And then you have to offer different food, okay, before you can say my baby is not taking that. So it's very unlikely. And then when you offer this food, it's just a small quantity for day one. 1 or 3 spoons is enough. Sometimes mothers say my baby is not taking enough food. What they are trying to say is that I give the same volume I used to give for the formula, and baby didn't take only maybe 1 or 2 spoons, and then that is it. And now that means baby is not taking that one. No, that is not true. So when you are introducing complementary food, you have to do it gradually. So the first day, 1 spoon is enough. It's okay. That is still enough. Then you can go to 2 spoons or 3 spoons, and then the quantity that is age appropriate. So all these are all simple things. And I always tell mothers the most important thing when it comes to doing complementary feeds is patience and persistence. So we cannot say a 6 month old has not taken any other food. That is actually not going to be correct, because that means you've not even tried for 1 week or 1 month for us to begin to say, oh, this child is. Of course, there are children who have some issues around feeding and all the feeding uh, disorders and stuff, but very too early to say that now. So you just need to go watch all our videos on complementary feeding. Please, when you watch these videos, take your time to watch them and digest them. I know why I'm saying that, because a lot of people come and tell me, oh, Dr. Baby, I've watched all the videos. It's not helpful. But the question they ask tells me they've not watched the videos properly, or they were watching it, and like most mothers we do, we are multitasking. You're watching the video, it's playing on your laptop, or you're also, you won't get all the tips, because all these little tips are there. But if we are not paying attention and really focusing on it, we won't get it. Then we need to be patient. When we're introducing new food, is a little at a time, and then we gradually increase it. So let's be very patient, okay? So Kemi, you are just literally starting complementary feeding. So all your baby's food at this time is still breast milk. 80% of it is breast milk, but we know breast milk is no longer going to be enough. So you just now need to start adding the other food, and it's a gradual process. Just be patient. So watch those videos and then start trying them, and then you can access. And it's so important that we do it patiently at this stage, because most of the time we are busy mothers, I understand that, and so most of the time we just want the baby to eat as one of our tick box, one of the things you got to do as a mom, and so that you can move on to all the other 100 things on your list. And so most of us just want to give our children bottle. Number one, I hope you're not doing bottle feeding. You should not bottle feed complementary feeds. It has to be true cup and spoon. So throw away the bottle. Number two, so we need to get them right. Once you get it right, you are going to enjoy the benefits when the child is 1 year old and 2 years old, because they'll be eating normally. But most of us, we just go for bottle. It's easy to put cereals or milk and bottle, and we give our children, and then we move on. At the end of the day, then when it is time for them to actually eat the real food, then they won't eat it, and they will always want bottle. Then it's another battle again, which is what some people will ask us. So we need to get it, but once you get it right from that 6 months or 7 months old, with a lot of patience, you will just have a smooth sail by the time they're about 1 year old, when they should be on full family diet, eating exactly the same thing the rest of the family is eating. And let's not do bottle feeding of complementary feeds. I hope that is helpful. Instagram, ask question now. No question on Instagram. Okay. All right, let's move on. Idowu, Deborah Favor. Good evening. My baby will be 8 weeks tomorrow. What is the cause of reflux in a baby? What is the cause? Okay, I've always explained that, but it's not something you need to worry about. Okay, baby have reflux. There are what we call physiological reasons for it. Okay, it's a very common thing for baby to have reflux. Number one, babies are small. Okay, they are practically like that, and the space between their mouth and the tummy is literally that short. So you have a short space between the mouth and the stomach, and then they are eating liquid food, so liquid can flow either way. So and they are all on milk, and then most of us, when we finish feeding the babies, we just put them flat. So this is a baby with a short space between the mouth and the stomach, who is on liquid diets, who is now put down flat. And finally, there are what we call gates or sphincters in medical jargons. They're supposed to separate between the what we call the food pathway, the esophagus, and the stomach, where the food is going, so that when food is supposed to go back, the gates will close. That's why people can eat with their head down. You can eat with your head down, because when your food flow past the esophagus into your stomach, it doesn't, the gate will close. It won't flow back the other way. But in babies, that gate is not yet fully functional. It is not fully mature, so it doesn't close well. So it's easy for food to flow back. So these are the physiological reasons why babies can have reflux. So we expect that, because that's why we encourage you that when you breastfeed your babies, keep them upright. So let some gravity up you. So after the baby has finished eating, don't just, most of them when they finish sucking and they slept off. And most of the time we just go and put them down. No, because if you do that, then it's going to be reflux. So, but if you keep them upright 15 to 30 minutes, a little bit of gravity will keep the food down in the stomach. Then some of the digestion will start. So at least it will keep it down a bit. It's not 100%, but if a little is going to come out, it will be very small. Okay. So, and that is nothing to worry about. Maybe we'll be gaining weight, everything will be fine. But some people actually have what we call a reflux disease. So there's a difference between reflux and what we call gastroesophageal reflux disease or disorder. So some children, in addition to all these physiologic, the natural reasons I've mentioned, they tend to have a very bad reflux, like the food is always going backwards. And some of those kind of babies, we have to treat them. So they almost like practically bring back all the milk. Sometimes they are vomiting, sometimes they are not gaining weight. So if your child has a bad reflux or disease, that's how we call it, we need to treat that child. So there are medications we can give. And sometimes we thicken the milk. We have milk thickeners. We sometimes use that for preterm babies as well. Sometimes we give some medication like proton pump inhibitors and all that. We just give some medication to help for those kind of scenario. But most babies don't have that. Maybe practically less than 1% of children would have that scenario. Most children just have the regular reflux that as they get older, it will start getting better because they are bigger, they start to sit, so they are mostly in upright position. And then by the time they are about 1 year and they are on what we call a solid diet, reflux is practically gone at that point. So that is that scenario. Okay, I hope that's helpful. Let me know whether you have any further clarification. Okay, I don't think I have any question on Instagram except people want to be in my video. All right. Okay. This question from Ifoma Agbasi. Good evening. What is clonazepam drug used for? I always have issues with people asking those kind of questions. I have my reason for that. Okay. Number one, if your child is given any medication, it is the responsibility of the doctor who gives medication to explain why they're giving that medication, what that medication is meant to do, what are the side effects of that medication. Okay, so it is very important to have that conversation with your doctors. I don't like answering that question because I don't want people to go and start using self-medication and using medication because they now know what that medication is meant to do. So I don't like that. But clonazepam is like one of the family of diazepam. Most of us are familiar with diazepam, Valium. So clonazepam is one of those kind of drugs. So we use it to treat convulsions. We use it to treat other neurological conditions. It's a very serious drug. It's not a drug you should ever use without a doctor prescribing it for you. Okay. Your daughter was having some shake in her leg when she was awake, 3 weeks old, and doctor suspects benign sleep myoclonus, and she was put on clonazepam. That's not. That should never happen. We don't treat if the doctor suspects benign sleep myoclonus, then the doctor should not treat the child with medication. That doesn't they don't that statement doesn't go together in the same sentence. Okay, number one, a child should not be put on clonazepam or any medication at all for benign sleep myoclonus. That is number one. So if your doctor is giving you an anti-epileptic medication, then that means that doctor is saying your child has epilepsy, not benign sleep myoclonus. Okay. Okay. There are lots of information about your baby which you have not told us. I strongly believe no doctor, no trained doctor will start a child on anti-epileptic medication for benign sleep myoclonus. It should never happen. That's number one. Number two, if your doctor is putting your child on that kind of a medication, you should be having a serious conversation about it. They should be telling you what is wrong. Now you are putting in the information about cerebral palsy. So did they have a conversation with you whether your child has cerebral palsy before now? Why would they just suddenly? So it's not something that will spring up on you out of the blue. So you really need to tell us what was the problem with this your baby at the beginning. Did your baby have any problem in pregnancy? Was there any problem at birth? Was there any complications of that child's delivery? Were there any other issues? So you've not given us that background. That's the issue when you pick and select what information you want to tell us. Okay. I always have issues with that. So if you want me to answer this question, then tell me everything, okay? So that I have the right scenario to make a judgment. But based on what you've written, that should not happen. Nobody should put a child on clonazepam for benign sleep myoclonus. Nobody should do that, and nobody will ever do that. So if I hope that is your doctor a pediatrician, and this actually this is not even a medication non-pediatrician should be prescribing for a 3-week-old baby. So there are so many issues going on here, and I have a lot of issues with that. And but if you want me to answer it, you can provide more information. But I hope you should go and have that conversation also with your doctor. You really need to know what is wrong with your baby. Why is your baby given this medication? What are the other issues your baby has? So it's not something that doctors would do normally. So let me just stop it at that point. Okay, Blessing say my baby do sweat on his face when I wear him cap. That is normal now. You wear people sweats normally, and if you think you're wearing cap, it's not written in the constitution that you have to wear baby caps. I see mothers do that a lot. We wear caps, we wear socks, we wear mittens, and it's as if that is how baby should be dressed. And some mothers are even, Africa, it takes a village to raise a child. So some so-called experienced mothers, when they see a mother with a baby who doesn't have all those three things on them, then they start to scold the mother. There is no law against such. There is no law. There's no law that say you have to wear caps and socks and mittens for babies. There's no law. It's not written in any constitution. The pediatrician did not sign into that. Okay, so if your baby is cold, you wear extra layers of clothing, so you can put on cap and mittens or socks. If the child is cold, the weather is cold. If the child is hot, please dispose of those things. It's not necessary. Okay, so your child does, even rainy season or not rainy season, does not mean the child has to wear caps. Okay, it is the temperature, weather. What's the temperature? Is it hot? Is it cold? And that's what you should do. So you don't have to wear a child cap even when the child is sweating, which of course common sense is telling us already that a child who is sweating is hot. So why do we need to put the cap on the child? There's no law, okay? So be free from that law. So you don't need to put on any cap, you don't need to wear any socks. Dress your baby, and I'm assuming that even at this time you're also wearing maybe thick layers of clothes and sweater and everything. The child will be hot. Then later we start having heat rashes, and then we're going to come to the pediatrician for the heat rashes. So dress your baby according to the weather. So if you feel your baby's hands, the hands are cold, to touch, then that means the baby is cold. You can wear extra layers. The baby is warm, is sweaty, dispose of some layers. There's no particular law how we're going to tell you how to do that. You just use your own initiative as a mother. So just understand the principle. If your child is cold, wear extra layers, wear the cap or socks or mittens. If the child is hot, get rid of them. You don't always have to wear it. Okay. Actually, this was living in Africa. Africa is really hot, so why should we be wearing most of these things for our babies? If Ama is asking, she's 3 months, so she's carrying her head, bringing her head. If Ama, I can't really answer your question because there are lots of things that is not making meaning to me. Number one, if your doctor is it your doctor that told you your baby has benign sleep myoclonus, or you are the one that's come up with that? So then number two, if a doctor is putting your child on clonazepam, that medication is a very serious medication. These are not the kind of medication we use every day. It's not paracetamol. It's not ampiclos or amoxil. It's a very serious medication. It's a medication we use for brain issues. It's a medication you don't just put a child on and the mother is confused as to why that child is on that medication. So I really have issues with that. The fact that you're asking me questions for a child who is on that kind of a medication alone is worrying me a lot. And from what you told me, it seemed like your baby was fine, there's no problem. So why would then the doctor put your child on clonazepam? Did the child have an EEG? Did they do a test to confirm the child is having seizures and all that? It's not a medication we use every day. It's not a medication we'll just put any child on. So it's a medication that should be put on by a pediatrician, preferably even a pediatric neurologist, specialist, and not even just any everyday doctor. So I have a lot of issues with that. So I really, if you, like I said, if you want to go into more details, that's fine. But if you don't want to do that, I understand. So I will recommend you go have that conversation with that doctor first. It's very, very important. Otherwise, I worry so much about that. Okay, let's move on. In the woods, thank you for this. Okay, you're welcome. Adekitsade, good evening. My daughter of 2 months is having this congested nose, and we use nose decongestant. Please don't. In a 2-month-old, don't use anything to decongest anything. There's nothing to decongest in a 2-month-old. Just don't give any medication. When you want to use medication, can you please read the leaflets? Because they always tell you whether that medication is appropriate for that child's age or not. And I'm sure there's nobody who will write a decongestant for a 2-month-old. They would it's not possible. Even a mother was asking me the other day about Actifed because she read it and she now realized that she should not be used in children less than 2 years. Sarah, this medication have age. So, which is why we want you not to do self-medication, okay? There's nothing to flush. There's nothing to do in a 2-month-old. Don't use any medication for catarrh, for cough. The only thing we allow you to use is if the nose is blocked and you can see that there's mucus that is there and it is really blocked and the mucus cannot flow out because children cannot sneeze at 2 months old. It's normal saline, the normal saline, the same salt and water that you have in your kitchen. That is all. And just 1 drop of saline to soften the mucus. It's not treating anything. It will soften the mucus and make the mucus to flow out. That's all. We don't use any drugs in 2-month-old for any, there's nothing decongesting, there's nothing to decongest. In a 2-month-old, there's nothing to decongest. Okay, if your child is snoring and all that, please see a pediatrician, okay? Most of the noise that most of us think is this, there's actually nothing wrong with the baby. There are some noises that babies can make that are actually normal, because the reason why they make those noises is because the airway area is not as hard like that of adults, so it's a little bit flexible. So sometimes when hair is flowing, it can flow either way. And the noses are very small. I hope you notice that babies' noses are very small. So it's very tiny. And babies breathe only through their nostrils. So if any little thing, even just a little bit of mucus, block a little bit of their nose, you are going to hear a lot of noise that looks way out of proportion to whatever is there. And what we, like I said, if there's something blocking the nose, like mucus, we just put saline to soften the mucus and the mucus flow out. And if the mucus is flowing out, you don't need to use normal saline, because a lot of people also think, oh, I should go and use normal saline drops. You don't have to use saline drops if the child is already having the mucus flowing out. The saline is not a treatment for for whatever the child has. It's just to soften the mucus and make it to flow out. That's what can block the nose. So if there's no mucus or the mucus is flowing out, you don't need to use anything, okay? And if your child is having noisy breathing, but you are not sure why the child is having noisy breathing, please, you must always see a pediatrician. Don't use any drugs at all. No drugs. Even some of these nasal drops, a lot of us go to pharmacy and they give you Otravine. Otravine is a steroid. Please don't use it in babies. You should never be using those kind of drugs or nasal drops in babies without an ENT doctor prescribing it for you. And they won't prescribe it in a 2-month-old. Okay? So we do a lot of self-medication. I understand why some of us have to do self-medication, but please, when it comes to babies, don't do self-medication. Don't at all. So don't do so. I'm okay with you doing some medication for yourself as adults, but please, for our babies, spare them. Just leave them alone. If you don't know what to do, come and ask us or come and see us. Don't self-medicate babies. Some of these drugs are dangerous in babies. Some of them have terrible side effects. So please, we don't want you to use them. And if you really read the leaflet, you will see it written there that don't use it. They would have written it there. So most of us don't bother reading those leaflets. And or maybe they are the ones that people some people do a lot of things, yeah, but please, I will just stop there. Okay. I really worry when people use medication wrongly in babies, especially. It worries me. Okay, Pharma is giving us one indication. Your baby was 38 weeks. When we had after some days, we checked for jaundice and it was showing 18.5. 18.5 is quite high. You didn't say, when you say after some days, your baby is practically 3 weeks old. In this kind of age group, tell us everything per day. The baby is 3 weeks. So when you say some days, is it 1 day, 2 days? It's very important. Just say 2 days on the second day of life, third day of life, baby had jaundice. It's more relevant than say after some days. There is a level of jaundice at day one that will worry me, which may not worry me at day 7 or day 12. Those things are very important. So your baby was on phototherapy and it went off. She had sepsis. Okay, she was treated, got better. How many weeks was she treated for the sepsis? She was shaking in her right leg. Took her to a teaching hospital. So they do ECG or EEG. Exactly, exactly. So your baby has had a lot of investigation. So you see, that's okay. All right. So that's why this is what you should have told us first, because I know that people don't just put the baby on clonazepam. So your child already has a lot of background issues that can affect the brain. And I have a feeling it's EEG you did. Or is it a CT scan? Because ECG is for the heart, but I assume it's EEG. Unfortunately, your message has been cut off by Facebook. It was becoming too long. You can send extra. Okay, so if you've been to a teaching hospital, you've seen a pediatrician, they've done an EEG, they've done a brain scan, most likely, and yeah, so there's your child, they didn't tell you your child has been nice sleep myoclonus. You are the one that gave us the confession. Okay, if your child has had an EEG and there's some vocal dysfunction in the EEG, your child has epilepsy. That is what the child has. It is not benign sleep myoclonus. We won't do EEG in benign sleep myoclonus. EEG will not show anything in benign sleep myoclonus. So this child is being treated as a child who has epilepsy. That is what it is. And if that is what your doctors are treating, yeah, that's fine. But they should be explaining all these things to you. Unless, sometimes, because I know, I know me too, I have patients like that as well. Sometimes we're telling you something, but you have not really embraced it, or you are in denial of it, which is completely normal, natural reaction of a mother. But I can see where your doctors are coming from. Your child already has a lot of issues that worries them, that this child may have brain issues, and they've done an EEG and they've seen something abnormal on the EEG, and your child is shaking. And I have a feeling that shaking is a seizure. It's not just benign sleep myoclonus, because benign sleep myoclonus is the child that will shake for a few seconds, maybe when they're about to sleep or waking up from sleep. Not this must have been something the child is really shaking, and is shaking the right leg, and they could see something on the brains, on the EEG, that seem to match what they are saying. So there's more to it. Okay, so you see why I always tell you I can't always answer questions when you don't give us the information, because if I just run with benign sleep myoclonus, then I will say it is wrong for your child to take clonazepam. But your child obviously has been seen by somebody who thinks the child has epilepsy, and that is what they are treating. Okay, so you can have that conversation with them, because I think the issue is that you don't really understand what they are dealing with in your baby, and it is important you should. It's a very serious issue. Like I told you, clonazepam is not a medication we use lightly. It is not. It is not. It's not a medication we use lightly. We use it. It's a very serious medication. Let me just put it that way. Okay. No, I can't answer your question about cerebral palsy. It is too late. It's too early. Your baby is 3 weeks old. We can't answer question about is it 3 months old or 3 weeks old? I think you said 3 months old in one, and you said 3 months old. Yeah, 3 months old. So cerebral palsy is a different thing from epilepsy. They are two different things. And I don't know why you are so worried about cerebral palsy. You should focus more on what your child is actually having. Your child does not seem to be showing signs of cerebral palsy now because it's too early. Cerebral palsy means there's motor delay. Your child is just barely 3 months old. It's just barely, achieved. So it's too early for us to check whether the child is going to have motor delay or not. Maybe by the time the child is about 1 year, we will know. But from what you say your child is carrying the neck and all that. That sounds a bit normal to me. So that doesn't sound like cerebral palsy. But don't quote me because it's too early to talk about cerebral palsy. There's a risk. I have a feeling they told you already that your baby is at risk of cerebral palsy, but I can't say your baby has cerebral palsy now. Shaking of the leg is not cerebral palsy. Shaking of the leg with EEG that is abnormal is epilepsy. They are two different things, okay? But they can happen together in the same child. Okay, so yeah, so just keep going for your checkup and have this conversation with your doctors. I really think you need, when next you go, seek the consultants. Tell them you don't understand what is happening with your baby. You want to understand what is going on, what they're treating. So speak to them. I have a feeling that somebody must have suspected your baby has benign sleep myoclonus first, maybe the first doctor you saw when you got to the hospital. But obviously they've done other tests and they've kind of override that one. And now they are treating your child like epilepsy. That's one I can tell you for free. The medication they're giving is an anti-epileptic medication. It is used to treat children who are having convulsions or seizures, like we call it. Okay, that's what they're treating the child as. And that is why they are still keeping you under follow-up. And that's what they meant by telling you the child will have to take that medication until the shaking stops. Obviously, this shaking is happening more frequently. It's not something that happens once in a while and go away. And it's going to be a long-term medication. It's not a medication you're going to use for weeks. You're going to use for months, even 1 or 2 years. So, but your doctor will be monitoring and be checking. If it's not better, they may want to change the medication and all that. I'm not the best person to counsel you because I don't have all the information. All the information I'm having is the information you're giving me. There may be more information that your doctor may have that you don't even know, or you may not be able to say it to me the way they may have said it to you, because they always tell you what you can easily understand. But I really, really want you to, when next you go to your doctors, please let them explain everything to you. It's very important. You really need to understand it. Let them break it down to you. Let them explain it to you in everyday language so that you can, ensure that baby is getting the right support. Okay. So I'm happy you've gotten that. If you're in, I think my time is up, but let me just quickly finish this last question and tell you about our anniversary. If I saying a child with delay in speech diagnosis and is presently working with speech therapists, does it take long for the child to speak? Okay, can you just start with the age of the child? Very important for you to tell us the age of the child. And that's number one. Number two, we don't have a manual for knowing when a child will talk. That is the honest truth. So we just do our best. Okay, no speech therapist will tell you when your child is going to talk. And some children will talk and some children may never talk. We never know. What we normally do is to give the children the skills on the opportunity to learn, and then we wait. But the truth is that nobody will know how long it's going to take. And depending on whether the child also has underlying medical diagnosis. For example, if a child just has speech delay, there was no other medical issue, most of them will talk within a few, it didn't tell us the age of the child, but most children should be talking by the age of 5. But if a child has autism, for example, if a child has cerebral palsy and speech delay is reason why that child is not talking, the cerebral palsy or autism is why that child is not talking. It depends on the severity of the autism or the cerebral palsy. So there are people with cerebral palsy who will never talk. They have very severe cerebral palsy. They will never talk. They will be completely nonverbal. We also have people with autism, even as adults, they will never talk. So what we normally do for such people is to give them what we call alternative augmented form of communication, AAC. So they can use their laptop to talk, they can use gesture, they can use sign language. Everything doesn't have to be with words. There are many ways of communicating. The most important is that the child can communicate. So can the child communicate with sign language, with gestures, or can the child use picture cards, text, and all that? So we use different things to do communication. So, but your if question is so vague, I can't really make out much of it. But the honest truth is that nobody can tell you when something is going to happen. We just do our best and leave the rest to God. All right. Thank you so much, everyone. Thank you so much. Thank you for joining me. I didn't see any question on Instagram today, which is very, very unusual. I hope I'm on the right Instagram page. Okay, I think I am. All right. So our time is up, but I just want to wish you all Happy New Month in advance. And then while wishing you Happy New Month, we also want to wish ATP happy 10th anniversary. So it's our 10th anniversary from July, and we are celebrating the whole of July. So it's going to be awesome. So we have a lot of programs lined up. So I want you to make sure you're following us every day of July. There's something we're going to be doing every day. It's a 1 month long celebration of ATP at 10. And so you can see the program. Don't worry, we'll send you the details, but make sure you follow us on our page. And then you will see all we're going to have. We want you to tell us how ATP has been impacting you as a individual, as a family. Tell us your ATP story. Of course, we're going to be having ATP trivia. We're going to celebrate all the people that have been there for ATP for the past 10 years, all our sponsors, all our donors, all our volunteers, our moderators. And of course, we're going to relive how the journey has been for the past 10 years. It's been a marvelous journey for us, and we just want you to celebrate with us for the whole month of July. So July 5th, starting tomorrow, we're going to be celebrating ATP at 10. And I think tomorrow we're just going to launch and tell you about all our events. So watch out for all the ATP lives, watch out for all the things that will be coming up on our Facebook pages, Instagram, and just also more importantly, want to tell us about your ATP story and celebrate with us at 10. And we're going to be telling you what the journey is going to be again for the next decade, the vision for the next decade. So I just want to tell you that. So watch out for all the ATP anniversary events coming up from July 1st to July 31st. And of course, the 20th of July is actually the ATP day. That's actually our 10th anniversary on the dot. And we're going to have a party. So watch out for that as well. It's really for our volunteers. We're going to join us locally, and we're going to celebrate it together online. So you can watch out for that as well. So that is my announcement for you. So I thank you so much for those who have joined me today. And I wish you a wonderful evening. I'll see you tomorrow. Tomorrow is our first day of ATP celebration, and it's going to be awesome. All right. Have a wonderful evening. Bye-bye from me now. Bye.